Can we have the video, please? Warm welcome once again at AIG Hospitals. It is Dr. Rupa Banerjee, and with me is Dr. Partha Pal on a very important subject, that is pediatric IBD, and I feel which is the most ignored and most under-evaluated in the entire Emerging Nations Consortium region across South Asia, Southeast Asia, Middle East, as well as Africa. So we conducted a survey this time when we were doing the registrations, and I'll hand it over to Partha to just quickly share on what we found on the background information on pediatric IBD management in this part of the world.
So we did this survey while registering for this fourth IBD Masterclass, IBD-ENC, and in this survey we have found that most of the participants were gastroenterologists, followed by there were some GI fellows as well, and pediatric gastroenterologists consisted of 13% of the total survey. And most of them actually only 10% did not see any pediatric IBD patient in their practice. Most of them, rest of the 90% actually see in different frequency, but still they see pediatric IBD in their practice. So when they are asked whether they are confident in managing pediatric IBD in their practice, 35% said yes, they can independently manage, but rest of them said that yes, they manage, but with the support from a pediatrician or a gastroenterologist. Whereas only 1/4 said they are not confident. Regarding the most common symptoms, it was abdominal pain and diarrhea, and followed by weight loss, growth retardation, and anemia. Then most of the centers had colonoscopic facilities, but MRE facilities are available in almost 60% of the centers, whereas not available in around 40%. And the first drug used for pediatric ulcerative colitis was mesalamine, whereas for pediatric Crohn's, it is corticosteroids. And most of them do not use biologics in children less than 12 years of age. Almost the division was 75% and 25% used biologics. And regarding the exclusive enteral nutrition, the jury was almost half in pediatric IBD. 50% used exclusive enteral nutrition, whereas less than 50% did not use. So most probably after this IBD-ENC masterclass, most of us will be confident to at least treat this pediatric IBD patients. And thank you, and over to the moderators.
I think we'll quickly begin with our first speaker for the evening, and that is Professor Dan Turner. Dan Turner does not need any introduction. He's one of the global top leaders for pediatric inflammatory bowel disease. He is the director of Pediatric Gastroenterology and Nutrition Unit at the Sher Zedek Medical Center in Israel. And over to you, Dan, for the first and the most important talk of the evening. Pediatric IBD, how is it different?
Thank you very much, Rupa, not only for the too kind introduction, but also for the invitation. I think for me it's always exciting to chat and to discuss with other parts of the world. I learn a lot from the practice of other people and other cultures. And I think it's only with the combination, everyone together, we can optimize treatment of IBD. Anyway, we're going to talk today about how IBD in children differ than adults. I think it's relevant not only for pediatricians, but also for adults treating adults, because pediatric onset IBD tends to be unique also when the children mature and become adults as well. So I think it's applicable to everyone, what I'm going to discuss. This is my conflict of interest. And if I need to give a title to the talk, does it differ? Well, I would say it is same disease, but more things. When I saw this title, I couldn't resist thinking about the change of the prime minister in Israel. I think it's still the same disease, but it became even more frustrating. But that's what we have in politics. Anyway, we're going back to IBD now. So pediatric IBD is the same, but there is more inflammation. It's more extensive. There's more genetics, more cytokine, more treatment benefit, more issues altogether. We'll try in the next 20 minutes to give a brief overview of all these topics. Well, the one thing is that children are being treated more often than in adults. These are data from the EPI-IRN that I presented yesterday at ECHO. All IBD patients in Israel 2005 are being followed and are registered in Jerusalem in the hospital. So we have children and adults. So we have 17,000 patients in the registry with Crohn's disease, and that translates to 115,000 person a year. So when we look at what medication people get in Israel now, so with the adults, we can see that there is a huge increase in the use of biologics, and now roughly 25% of adults are being treated with biologics. Thiopurines increased until 2003 and then declining, and with that there's a slight decrease in the use of steroids. However, when we see what happens in children, well, children are being used twice as often, more frequently, with biologics and immunosuppressants. So the trends are the same, but more than 50% are on biologics. There's a high use of methotrexate, a little bit more decline in the thiopurines and steroids. So children for sure are being treated more often, but what happens with their outcome? Is surgery is better? No, actually the outcome is worse than in adults, despite the high utilization of immunosuppressants. So this is the data again of of 17,000 people in Israel. We can see that surgery rate over the years declined in the adults, but not in children. It's about 4% annual risk of surgery. And that's been replicated in many courts around the world. Children are being treated more often, but still have worse outcomes. And this is not only in Crohn's, we can see that in ulcerative colitis as well. UC activity at presentation is worse in children, only 1/3 have mild disease versus 50% with adults. This is translated to more often need for hospitalization for acute severe colitis more frequently and more and shortly after disease diagnosis. This might be a factor of the fact that that pediatric onset IBD is associated with more extensive disease, and that had been shown for Crohn's disease and also for ulcerative colitis. So when you see about 80% of children have pancolitis versus less than 50% in adults, and also for panenteric disease in Crohn's disease is nearly 50% versus only 3% in adults. So this surely translates to a more severe disease. And everything together might be a factor of genetics. I mean, there's a reason why the disease is presented during childhood rather than in adults, and it's probably related to a more stronger genetic factor. And indeed, there are several genes that are associated with pediatric IBD and not with adult onset IBD. We can look at it in a different way. We know that Crohn's disease is associated with more genetics than ulcerative colitis, and since children are more genetic than adults, and Crohn's disease is more genetic than UC, then it won't be surprised to you to see that the entire state of Israel, we see in children less often ulcerative colitis than in adults. So we can see that only 1/3 of children have ulcerative colitis compared to about 50% of adults. And again, this is replicable in many countries around the world, showing that children have more often Crohn's disease than you see, and that's a reflection of the strong good genetic influence that pediatric onset IBD carries. There is one thing about genetics, and that's very early onset IBD. I will not go into details with that part because it's going to be covered very nicely by Malti in the second talk. But we have to realize that monogenetic IBD is slightly different than the genetic polygene we just talked about, but nonetheless, even those are distinct phenotype, it's still very, very rare in our, as I said, as I described the EPIRM, which is the cohort of all IBD patients in Israel, only 1.4% of the IBD population were diagnosed earlier than 6 years, and only 0.4% earlier than 2 years. So VOIBD, at least in Israel, is very rare phenotype, and distinct that needs to be treated, but still most patients in the pediatrics are being treated like in adults. Why? Because the genetic and phenotypic differences that I just described to you do not influence treatment effect. And I will show you what I mean. All IBD drugs that work in adults works also in children, and that makes things simpler for adult gastroenterologists that want to treat children. And this is a slide showing the results of the randomized controlled trial of regulatory trials for the FDA. We can see that infliximab for UC and Crohn's disease, adalimumab for Crohn's and ulcerative colitis. The blue is the placebo, the purple is the adult effect, and the red is the corresponding pediatric effect. And you can see that not only it is not worse than in adults, in most of the studies, the pediatric effect was actually better than seen in adults. And this is consistent with studies even outside the biologic era, showing that in general, the effect of drugs in children in clinical trials is better than seen in adults, never worse. There is not one precedent of a drug working in adults not working in children. But this is not because the disease is different, it's just because the population eligible for the trials is different, and typically you see more patients in pediatric trial that have shorter disease duration than seen in adult trial. We know, as seen in this cartoon, that when you treat earlier during the disease course, it is associated with better response. And I think this is what happens in the clinical trial. This is an example of the infliximab in Crohn's disease. So you can see here accent in adults and rich in children. And when you look at the median disease duration in the eligible patients enrolled in these studies, so the pediatric study is 2.4 years versus 8 years in adults, and this is associated probably with a better response. Otherwise, you get exactly the same response in children and in adults. But it doesn't mean that you don't need any pediatric studies. It doesn't mean that you don't need to read pediatric studies, because dosing must be different, because children are not little adults in regard to dosing. So I'll give you an example from the golimumab for the Symphony anti-TNF pediatric trial. The levels, the pharmacokinetics of the children enrolled in that study at week 6 was very comparable on average to the adult pharmacokinetics. However, if you stratify this to the children over adolescents weighing more than 45 kilos, or the younger ones, you can see a clear difference between the two populations. So the adolescents more than 45 kilos are just like adults, right, for everything. I don't consider them children, really. So a 16-year-old boy or girl can be treated very comfortably by adult GI if they have knowledge about growth and age-specific issues. But the little children are an issue. And we can see that with biologic as well. We can see that with infliximab in Crohn's disease to the left, and we can see that with infliximab in ulcerative colitis trial to the right. And you can see that wherever you look at it, the younger children, here the blue for 6 to 11 years, here the blue is less than 5 years, and the red is 6 to 7, they have lower drug levels in the blood, although they received the same per kilo dosing. Why is that? Because the little children, as you go less than 30 kilos, you need higher per kilo dosing than you do for adults to get the same levels in the blood. Why? Because the children are not proportional to the body surface area in kilo, and therefore you probably want to dose per body surface area or treat higher per kilo. So you need to know how to dose the little children, especially biologics. You have to treat to dose high, especially in the younger one. So what can we extrapolate from adults and what we know from the study? Effectiveness, for sure, that's my opinion. I think the FDA approves partial extrapolation, but I think most of us do extrapolate in the everyday practice anyway. But we cannot extrapolate from adult safety, we cannot extrapolate dosing, and we need to look at body surface area or per kilo and age-specific outcome, osteopenia, growth, disability, quality of life, body image. And this is a huge issue because children do have specific age-related consideration and complication. Because if you look at complication, you ask an adult IBDolog, what are the complication? He will say stenosis and fistula. But in children, we have more, and this is A, height, and B, bones. These are significant complications, what we see in adults. And we know already that prior to the biologic area, roughly 1/4 of the children did not attain their expected height when they reach adulthood. And about 50% of children with Crohn's disease do have height velocity impairment. The same thing, but not the same thing goes with ulcerative colitis. When you look at Z-score for ulcerative of height velocity in ulcerative colitis, you see that the same distribution as in the general population with a median and average of 0. That means that there is no growth impairment in children with ulcerative colitis, where there is, yes, in Crohn's disease. The same thing goes with osteopenia. So 50% of Crohn's children have some sort of osteopenia, and about 1/4 of them will have severe osteopenia. Regarding ulcerative colitis, the same as in with the growth, only 1/4, only 10% will have severe osteopenia. And this is a huge issue, although we don't see that in children because they feel good. But if we don't measure it by DEXA scan and explore what's happening over time, then when they reach 40 or 50 years of age, they have already hip fractures, as I see here, as I show here on the slide, on a population-based analysis from the States. What is the reason why children have growth impairment and osteopenia? Well, many people, that's what they say as a knee-jerk. Well, there is chronic nutritional insufficiency, problem with absorption, corticosteroid use. All these are in the margin, but the main thing is the ongoing inflammation. There is direct interference by pro-inflammatory cytokine, IL-6, IL-1, tumor necrosis factor on the IGF-1, not allowing it to work on the growth plate of the bone, or they inhibits the osteoblast and provoke the osteoclast to work. And until we reach endoscopic healing of these patients, we cannot reverse the growth, we cannot reverse the osteopenia, and any pediatric IBD expert know that we need to target complete endoscopic healing, and we discussed it way before adult IBD discussed that in the first stride. And indeed, when you look at the new stride that we just published from IBD in gastroenterology, for the first time you can see that part of the targets in children is normal growth, and to reach normal growth, you have to first decrease the calprotectin, CRP, and achieve endoscopic healing. Otherwise, it will not work. We have a very narrow window of opportunity to reverse the growth impairment and osteopenia, and for that we are trying to be very intensive in our treatment early during the disease course in order to reverse this damage. Otherwise, there is irreversible damage for the rest of the life. We have, with osteopenia, until the age of 2022, this is our window of opportunity with growth 17, 18, 19 maybe, and this is it, and then it goes. But the problem is that what we think about treatment to target and endoscopic healing and normalization of calprotectin, our patients, the children, they think about something else. They want to be free of pain, free of drugs. They don't want the drug. They don't think about endoscopic healing. There are other things. There are friends, there's school, there are other things that is bothering them. And then very often, more often in children than in adults, we reach this situation in clinic where we sit in front of the adolescent. They are not compliant with treatment. They do not understand. They are frustrated. They are angry. They don't know why they have the disease, and they don't want to take the treatment. And therefore, there is 40% of our patients in children are not adherent to therapy. And that is a huge issue. And for some, and when you treat children, you have to treat it in a way to try to reconcile everything and to engage your patient and your adolescent in a way that your goals and their goals are aligned. If you don't do that, they will not take your treatment and they will not comply with your recommendation. How do you do that? Well, it's called shared decision making. I think it's relevant for adult patients as well, but I think it's more important for children and their parents. I will not go into how you do shared decision making because this is a topic for a separate lecture, but I will say that there is 3 phases. One, it's a choice talk or a choice part of the talk. Everything can be in one clinic or in 3 different clinics. One, let your patient understand that they do have a choice. The second talk or the second part is give them the options, still without judgment. So when they have an option and they know they can choose and they chose the option, then it's more likely that they will comply with that option and will continue as we want. And then obviously there's decision talk when you give all the different information that they need and you take it from there with the decision. There are gazillions of randomized controlled trials for showing that if you follow shared decision making in your clinic, this is associated with better outcome of your patient and better compliance with treatment. And that brings me to the second part, that any gastroenterologist caring for children have to have a support program in some degree or some sort, which is convenient for the center. Adolescents with IBD, with chronic disease, carry significant morbidity or emotional morbidity, and sometimes even more than that, depression, body image, feeling of frustration, problem with their family. And we need to provide the care to address that. I think this is, again, important also for adults, but maybe more so in children. We do that is an example from Shaarei Tzedek Medical Center in Jerusalem. We have every 3 weeks, we have support groups. Twice a year, we have big events outside with psychologists to try to empower the children and give them the feeling that they can do everything despite the disease. We work quite a lot on this regards. This is also important because in children we discuss a lot about nutrition. The nutrition that we give in children, I'm not talking, this is not a nutrition talk, but you cannot talk about pediatric IBD without discussing it. So we do treat a lot with exclusive enteral nutrition with formula only, but we started doing the last 3 or 4 years to switch our patient to tasty and healthy diet. It's an exclusion diet of the ingredients that you see here. And other than that, it does not require formula, and it's not structured by the food that are allowed. And it works very well with 70% clinical remission, and about 1/4, 1/3 have endoscopic healing. Some of the patients, that's all they get without any treatment. But if you do that, again, you need support. You need to understand, you need shared decision making. You can see here of first 10 patients that open label just accepted for UEGW. Calprotectin with tasty and healthy normalizes in many of the patients. And we have activities, it's called, in Hebrew, the writing here is MasterChef. So we have activity with the children to empower them and to show them that, yes, they can comply with a exclusion diet, but still they have flexibility. They don't need formula. The outcome is good, and it's not the end of the world for them. And it can be, even the cooking can be fun. This is a nice MasterChef evening that we've done in Jerusalem. And to end, there is another difference between pediatric and adult IBDologs. if this is the parking in Jerusalem of pediatric GI, this is the parking of adult GI. They have more patients, more private work, but still we share the same heart to benefit for our patients, and there is more things alike than different between the two population. And I think pediatric IBD that have enough experience can treat adult IBD, and adult IBD gastroenterologists with the right training and the right sensitivity can easily treat pediatric IBD, especially the adolescent. That's for sure. Thank you very much.
Thank you very much, Dr. Dan. I think that was a very interesting presentation, and I quite liked the second slide that you put up, which mentions more inflammation, more extensive, more genetic, more Crohn's, and at the same time, equally responsive to the standard treatment as in adults. And that puts into a nutshell what pediatric IBD is all about. I am given to understand that you have to leave us in about half an hour's time, but we will definitely have a question answer session soon after the next talk, and by that time we hope to get some questions into the chat box.
Okay. Now, an hour time.
In an hour's time. So that means you can be a part of our panel discussion as well. Now,
and I'd ask all to send in their questions for Dan.
Yes. So we are waiting. While we are waiting for those questions, which of course Dr. Rupa will channelize, it's my pleasure to introduce to you the next speaker for the evening, Dr. Malti Satya Shekharan, who is a senior pediatric gastroenterologist at MGM Hospitals, Chennai, and one of the legends in pediatric gastroenterology in our country, with more than 30 years of clinical experience and a special interest in IBD, the testimony of which is the fact that she has published a lot in pediatric IBD, and she has, to her credit, a lot of publications in leading journals. Dr. Malti is going to talk to us about very early onset IBD, which Dr. Dan very, very carefully, kept aside, and he was careful enough to say that this is for Dr. Malti to deal with. Over to you, Malti, for the next talk.
Evening. It is indeed a great pleasure to be here, especially to share this virtual platform with Dr. Dan Turner. With such an excellent exposition of pediatric IBD, I feel humbled now. I was just hoping that he would cover more of early onset IBD, because he's done so much of work. All the references which I've taken, he's a co-author or even the first author of many of the papers. Thank you, Dr. Ramesh. You always boost us up and give us so much encouragement that goes on. So my topic is very early onset IBD. And Rupa has given a very interesting title, a distinct phenotype in pediatric IBD. Pediatric IBD itself is difficult. Now we are going to make it little more difficult for all of you. So I'll be covering this topic under these headings. And very, very early onset IBD, even the term is not even a decade old. It is probably just 9 years. We all know the Montreal classification, when they realized that they have to differentiate it from adult onset IBD. So they called it, whenever the onset was less than 17, they called it A1. And then Levine in 2011 made it again, he modified it again, and he divided that. When the onset is less than 10 years, he called it A1A, and the one which Montreal had, A1B. But in 2012, this terminology came. When we used it all, they found that there was something different, and as the child is younger at its onset, the problems are different, the presentation is different. So A1A, that is less than 10 years, was called as early onset IBD, and less than 6 years, very early onset IBD. When it first came, it was published, we also were quite confused. Why this depth, so much of, hair-splitting terminologies? Are we going to confuse it more between early onset IBD and very early onset IBD? But I think the specialists have beautifully shown why this is very important, that we have to look at these children in different ways because their presentation is different and their prognosis may be different. So very simply, we will just can say that very early onset IBD is a subset of pediatric IBD with onset of IBD less than 6 years of age. And this is an entity which has both phenotypically and genotypically different from the older age groups of PIBD. So not only is it phenotypically different as the title, but there is a genotypic difference, and that is what we'll be seeing today. And what happened in 2014, we had this most elegant paper, very well quoted throughout the world, and Dan Turner is one of the co-authors in that. It was a big group who joined together and then gave a very nice paper on monogenic IBD, when they said that very early onset IBD, yes, it is less than 6 years of age, but then you have this infantile onset IBD when then it is less than 2 years of age, and you also have a neonatal IBD. And their recent paper in JPG in 2021, they have reaffirmed it. Why should this hair-splitting differences be? The main reason probably is because very early onset IBD, their presentation as classic CD, classic UC may not be there, and 20% of them have present as IBDU. Whereas when the infant is less than 2 years of age, or the IO IBD, that becomes higher, 30%. The colon will look as if it is like Crohn's. The histopathology will come like UC. Because we know IBDU, then you are not sure where this will go. Will not know what will the complications be. And also the monogenic IBD, which Dr. Dan just mentioned, is much higher as the infants are younger. It is around 0 to 33%, depending on which monogenic IBD is there in VE-IOBD or less than 6 years, but it is quite high, 13 to 41% when it is infantile onset IBD. General incidence of the total PIBD, VE-IOBD or the very early onset IBD is usually around 4 to 15% all over the world, whereas infantile onset IBD 2 to 4%. But Dr. Dan said in Israel, this seems to be lower. Let us see what is it in India. In India, we published this paper in 2014. Most of the people, my colleagues are here, Anshu is here, Geeta is here, Maya. And at that time, we found that very early onset IBD was around 13%. Recently, under the guidance of Anshu and Dr. Rishi and all of them, a nice paper we could publish from 9 centers, 325 cases from 9 centers in India. And at that time, we found that less than 6 years of age, it is 19%. I'm not sure whether this is a rise or it is, we are identifying them more, or is it actual incidence is more. But over the years, we've seen papers from Canada. Benchimol had shown that when there was a cohort study, 3 cohort studies from Canada, they did find that very early onset IBD, there was an increase in 7%. Another paper from Scotland has also shown that that age group, there's an increase. French cohort has shown that early onset is increasing, but not. So on the whole, one should know that the incidence of PIBD is also showing a rise, and this subset is also being identified more, or the incidence itself is rising. Pathogenesis of PIBD, we all know this Venn diagram. We all know that there is an interplay of these 3 or 4 factors, but GWAS has shown that in adolescent and adult onset IBD, there are around 240 IBD-associated genetic loci, and this is known as the polygenic disorder. This is very simple. This is what we teach your PGs. This will be the adolescent and adult type of IBD, where you get IBD when there's an interplay of these factors: genetic susceptibility, an immune response, and an environmental trigger either within or from without. But when you look at very early onset IBD, you will see another wing coming from there. And this is that monogenic IBD, which I was showing, where using the next generation sequencing, either of whole genomes or studies or the whole exome studies, you find that there are specific single gene disorders, single gene monogenic disorders occurring in this group, which have an IBD-like illness. This is the monogenic disorder. So what is the phenotype different in very early onset IBD? From 2014, from the time this name introduced, people always found, this paper was from Alloy from Italy, over 506 patients, they found that the Crohn's disease was isolated colonic in this group compared to when they saw it in the older age onset, and UC was all pancolitis, statistically significant. When Australia, paper from Australia, where they had 60 comparators, the same results they got. When a large prospective study from North America of 1,928 children, they also found. So more or less, very early onset IBD, the Crohn's phenotype is isolated colonic, but UC is more pancolitis, and it's probably tendency to diagnose more of UC was their result. What about India? The recent paper which we published, we have shown that when we compared the very early onset IBD and the older age onset IBD, what was the differences? There were about 20 parameters which were compiled, and I really have to thank Rishi and Anshu for this wonderful work which they thought about and tabulated. IBDU was definitely higher in very early onset IBD. Weight Z score was much less in very early onset IBD, statistically significant, and pancolonic involvement in CD, just like what was in the West, is also shown in the Indian study. So what is the phenotype for very early onset IBD? Very simplified. When the child is less than 2 years of age, you will have more of the non-classical or monogenic IBD, whereas you will have the classic polygenic IBD as well as the non-classic monogenic IBD. And this is what will be the probable representation of maximum 25% of very early onset IBD showing monogenic IBD. So what is this monogenic IBD and why are we so worried about it? It is because they constitute a maximum of 25%, I told you, and they are seen in much younger. They have an aggressive type of IBD and they do not respond to your conventional treatment. You cannot just keep on pushing biologicals and keep on doing something like that, doing surgery. It is a complete different cup of tea. And so you have to have a different approach and you have to have a different management. They are rare Mendelian genetic disorders, mostly immune deficiencies or epithelial barrier defects with IBD-like inflammation. And there are 6 variants, either involving the intestinal barrier or bacterial recognition or IL-10, ILR. We need not go into everything, but what a big recent paper has come where they've seen all the cases of PIBD in US, and they have found that they did WES, that is exome sequencing for all the 1,005 children, and they found 3% of the total PIBD had monogenic disorders, and of them 1% can be corrected with allogenic HSCT, which you do not talk about in the management of PIBD. So in Chennai, when Srinivas and I looked at all our monogenic disorders from 2015 to 2020, we had 8 children, and of that we found that 3 of them had IL-10RB defects, 3 of them we did HSCT, 2 are in follow-up and they are doing well. LRBA, we had 2, 24%. We had 1 GUCYC2, that is epithelial barrier defect, DOC8, 1, and we also had a trichohepatico triaxis syndrome, the other last one we had. And this was one infant which presented with the GUCYC2 deficiency at the age of 9 months with blood in stools, erythema, hypoproteinemia, a very sick child, and look at the colon, large irregular ulcers, perianal involvement. Whenever you have a young child, a perianal involvement, having colonic ulcers, it is better to do genetic studies. So much of money we spend. All the other parameters, it will look very much like IBD. But then the thing is a GUCY2C. This will not respond to HSCT. That's very, very important. We also had this IL-10RB mutation, this child who presented with a rectovaginal fistula at the age of the 7th day, went to the surgeon and had surgery. And because of the different presentation, we thought this is IL-10R, and we could even publish this case, and HSCT has been done. This child is now 21 months, doing very well. So very, very important, another child. So once you know about this, when you see an infant with diarrhea, especially when there's a family history of consanguinity or a previous sibling, as this previous baby also, they had an elder sibling died of chronic diarrhea. Here also, similar illness in the previous sibling made us think and do genetic studies. Even at the age of 2 months, we had sent the blood and we got the result, and then we were able to do HSCT at the age of 5 months. So this IL-10R seems to be the most common monogenic disorder seen, especially in Asia. It inhibits the release of tumor necrosis factor, and it is an important anti-inflammatory cytokine. So any function defect of these two results in a 100% penetrance. That is why this is very important, but it seems to be more in Asia. Korea, 50%. China, they've had 38.5% of their PIBD presenting like that. Malaysia, they have reported, but not much from the West. So this seems to be a problem which we have to also concentrate. So when will you suspect monogenic IBD? All very early onset IBD are not monogenic. They are classical. But suppose you have an infant less than 2 years of age, there's a family history of consanguinity, perianal lesions, very in a young group, or in addition you have hair deformities or skin deformities, or you will suspect. And this acronym, which was coined much earlier in 2014, has been re-emphasized in the recent paper by Dan and his colleagues, where you said young age and multiple family members are the most important two parameters, and all the others are the red flag signs, especially autoimmunity. Suppose you have recurrent infections, skin infections, ear discharge, unexplained fever, you have HLH-like presentation or malignancy. Think of this. Think of the disease, and you have to do. But as Dr. Dan was telling, they have a report from Israel where they picked up a 37-year-old man with a monogenic disorder. So adult gastroenterologists should not think, oh, monogenic disorder is not for us. There may be a different type who can present later on. So if you have someone who's not responding well, one should even do at that age. So why should we identify? Why should we identify? Because their workup is different, their complications are different, they need genetic counseling. They are not going to improve with your immunosuppressants or your biologicals, and they require a different type of therapy. Surgery, you can avoid unnecessary surgery thinking it is the classical CD. So this is the usual workup which you will get in any book. You will have to do all the workup as for your IBD, but in addition, you may have to do other tests like your CBC, immunoglobulin profile, your lymphocyte subset, and then you go in for your IL-10 suppression test, workup for CGD, and then you will do your genetic testing. Which genetic testing we do in India, in our center and all, we prefer to do whole exome sequencing rather than genome sequencing, because we know that most of the diseases are in the exons of the genome. Though it comprises only 1%, you can cover much, and it is not as costly as genome testing, but little more costly than the targeted sequence, and you will be able to get at least that 40 to 50 type of genomes. Management, as Dr. Dan was saying, it is a multi-team approach. The usual team which we all talk about, but in addition, for monogenic, you need the hemato-oncologist, you need the genetist, you need the immunologist also to work. So the therapy for non-classical IBD or for monogenic, HSCT forms a bulk of management. Definitive treatment, especially in IL-10R and in WAS, probably in LRBA, variable in NEMO and XIAP, but not indicated in epithelial barrier defects. And then you have other types of defects also for CGD. You can give gamma globulin, and this probably you can read more. So the conclusions, I would like to say, it is a unique subset of a complex group of children, both phenotypically and genotypically different from the older onset. It comprises both classical and a smaller group of non-classical. Very important to recognize this group. I have told you when to suspect, and genomic studies, I think as you start growing, we'll be able to identify more. Targeted therapy and personalized precision medicine is the answer. And thank you for your patient listening.
Thank you very much, Dr. Malti. That was a detailed presentation on very early onset IBD. And I think what was very impressive was that 1 in 5 of pediatric IBD is very early onset IBD, which is actually a very significant fraction, isn't it? So we will come into the discussion about, pardon?
Just a quick questions have already come in for Dan.
Yes.
So I thought we'll just quickly cover both. Dan, the first question is from Dr. Mai Ling Piman. He, of course, says that this was a fantastic talk, but wants to know how old is your youngest patient and what personal challenges can you mention when you faced that particular patient for your youngest patients?
The youngest patient I ever treated started his symptoms at the age of 6 days of age. A Bedouin family from the south of Israel. Some genetic mutation, quite rare and not frequent. And I think that for the VOIBD, there were really fantastic talk by Malti. It's there are quite a few insights to point. One, I think many of the studies that provide the percentages of incidence of VOIBD, they are coming from highly specialized centers that treat VOIBD. It might be a little bit over emphasizing the number of the patients themselves. I don't know, but still, it's very ethnically determined. So, as my example was the Bedouin patient. I know that in China there's quite a lot VOIBD of IL-10 deficiency. I've never seen an IL-10 deficient. Well, in China, it's like they have 70 patients in Shanghai where I visited. So it's well, but we have other things that are positive. So it's very ethnic dependent, I think, VOIBD. For these patients, I have to say that on average, when you treat VOIBD, both in my center and when you look at cohorts, on average, VOIBD does not have worse outcomes than older patients. But there are subset of patients that you give a little bit of 5-ASA, salazopyrin, azathioprine, and they're great for years. And some patients, whatever you do with them, they have a horrible disease. So on average, you get the same. But the problem is to find the 20-30% that actually need the more intensified treatment and investigations. Not necessarily if you have less resources, you need to evaluate everyone exactly the same.
Another question for you, Dan, and this is from Dr. M.S. Vishwanathan. This is that can you throw some light on Crohn's disease exclusion diet and the role of FODMAP in IBD?
Okay, so the Tasty and Healthy that I showed you is based on excluding of the same foods that I excluded in CIDED. But unlike in CIDED, I think it's never been proven that you actually need the formula. If you ask me, I think it's nonsense. Because when the CIDED started, the first case series that the Aryeh and others published, there was no formula whatsoever, and it still worked. And actually, there is now a study, randomized controlled trial presented at DDW, not yet published, of Hanit Yana in adults, showing that CIDED with formula, without formula, exactly the same. So I think we don't need the formula. The second thing that I don't think it's justified. Once we take out the pro-inflammatory foods, I don't think it's justified to tell the patients if they need 2 carrots and 1 potato or 4 potatoes and 1 onion. I think it's not based on anything. So what we do, we take out the pro-inflammatory food, and then we tell the patients, you can eat whatever you like now. So fruits and vegetables and grains and rice and fish and chicken or poultry and eggs. Now you're allowed to eat whatever you like, whatever combination, in whatever quantity within these the allowed food. And once they enter remission and the calprotectin normalizes, we introduce gluten. Most patients will be fine with gluten and calprotectin will not increase. We do that then a little bit with cheese and that many patients will be okay. And that's it, and that's how they remain. So if you ask me, we do not give CDED, we give Tasty and Healthy. They are Helmsley funded $2.5 million, 2 randomized controlled trial that we're doing now with Tasty and Healthy. If there's any one of you that is interested to participate in this study, it's a very structured and nice study. Throw me a line via email, and we're happily going to include your site.
Dan, there is one more question from our co-moderator, Dr. Jayanti, and she asks you for an opinion. Has the genetic polymorphism changed, or is it that the genes have remained the same, but the environmental factors have changed, and that is responsible for the sudden change or high prevalence in children?
Well, I'm absolutely sure that it's environment. I think the genes didn't change. Maybe epigenetic change a little bit over the generation, but I think IBD, although there is about 1/3 of the pathogenesis of IBD is genetic, still 2/3 in environment. The genes have been there forever, and the fact that we're seeing increase of people from the Far East going into the Western world, and within one generation, the rate of IBD is becoming the same as in Canada and the US. That's only proof that it's environment only. And if we change the environment by food or by eating better, more farms, more animals, less antibiotics when not needed, then less hygiene, I think we can go down with the prevalence as well. We're just not there. And in your part of the world, unfortunately, it's just going up, as nicely been shown now with Malti.
Well, that's an interesting concept. Thank you very much. We will carry on the discussion after the next session. And the next session is a very interesting panel discussion. So what we've heard about, 2 talks. One is how pediatric IBD is different. Second is the concept of very early onset IBD. Now it's time to sort of look at the management or the diagnostic issues in pediatric IBD. And for that, I would like to invite and introduce the moderator of this panel, or the leader of this panel, Dr. Geeta M., who's my colleague here at Aster MedCity. She's one of the senior most pediatric gastroenterologists in Kerala, and very tall in stature, not matched by her physical stature, but very tall in stature as a gastroenterologist, as a pediatrician. And she will be leading this session on pediatric IBD diagnostic issues. Over to you, Geeta. And you may also introduce the panelists.
Thank you so much, Dr. G. N. Ramesh, for this very kind introduction. It's an absolute pleasure to be having a case discussion on a pediatric case today in the presence of Professor Dan Turner. And without any further delay, I'd like to introduce the eminent panelists, Professor Wei Lee, who's the professor and consultant pediatric gastroenterologist at the University of Malaya at Kuala Lumpur in Malaysia. Professor Anshu Srivastava, who needs no introduction. She's a professor of pediatric gastroenterology at the Sanjay Gandhi Institute of Medical Sciences in Lucknow. Dr. Srinivas, who is a senior pediatric gastroenterologist and consultant at Child's Trust Hospital and Apollo Children's Hospital. And Dr. Rishi Bolia, assistant professor in the Department of Pediatric Gastroenterology at All India Institute of Medical Sciences, Rishikesh. Now, Dr. Rupa has very aptly told us to have a very simple case and to have only discussions on the basics of pediatric gastroenterology, because the audience would want that. And so I would be concentrating on a clinical case presenting with bloody diarrhea. As we all know, bloody diarrhea or dysentery, as it's commonly known, is a common problem in children. And when they usually present in Southeast Asia or in emerging countries, the most common causes are definitely infections, which we cannot ignore. Some of these infections can last quite a while and can produce confusions in diagnosis for IBD. However, some of these patients eventually turn out to be IBD, could be UC or could even be Crohn's. Because of the bloody diarrhea, ulcerative colitis would be more in our minds. But how does a clinician who's sitting in his clinic and facing these patients, sift out the IBD? Are there any clinical pointers? Any tests that can be used for these patients? Any serological tests? Is fecal calprotectin the answer for these patients? And do we have to do imaging in all these cases? These are the questions we're trying to address today. We'll also be addressing a little bit on endoscopic biopsy. When it turns inconclusive, what should we be doing? Unfortunately, treatment will not be dealt with today because of lack of time, but I hope to do that in a different session, or maybe we'll have one more session if Dr. Rupa agrees, wherein we can sort out the treatment complications or treatment controversies in pediatric gastroenterology, pediatric IBD, sorry. So let's start with this case. It's an 8-year-old boy who's otherwise well with no significant past history, who started with symptoms of loose stools, which lasted for about 3 weeks duration. It started with all family members having loose stools and abdominal pain. All of them were suspected to have food poisoning and all of them were treated. All of them recovered except for this boy who continued to have semi-formed to watery stools, which has lasted about 5 to 6 times per day. Now he has developed nocturnal frequency of 1 to 2 times. He has tenesmus, abdominal cramps, and for the past 1 week, he also has been having blood and mucus in stools. He has no fever or vomiting. He's well in himself. And his appetite has reduced because of his gastrocolic reflex, and he's had a weight loss of about 1 kg. There's no history of drug intakes like NSAIDs. There's no family history of IBD. He was seen by his clinician after a course of self-medication, and then he was given metronidazole, cefixime, and ciprofloxacin, after which he still isn't better. On taking a deeper history, there's a past history of similar episode of dysentery about 2 months back, but that was a very short-lived duration. There was just blood and mucus about for a day or two. He was apparently treated with metronidazole and he had recovered, though there are no further details. Now I would like to invite Dr. Rishi to give us an idea that supposing this kind of a child presents in a clinic where the clinician has referred this case to him, what would be the common differential diagnosis that you would think about and you would want to consider before subjecting this patient to further testing? Dr. Rishi?
Right. Thank you, Dr. Geeta. So just to recapitulate, this is an 8-year-old child who's presented with abdominal pain, tenesmus, blood and mucus in stools. So basically, it's a child with colitis, an 8-year-old. Now, because the symptoms are relatively for a shorter duration, just 3 weeks, what I'll think of first in such a child would be infections, bacterial infections like Shigella, Salmonella, or E. coli. Now, in this child, there's a history that other family members were also affected. And as these infections, they are generally transmitted through contaminated food or water, it would suggest a common source. So that would kind of make me think even more that this is probably an infection. The odd thing here would be the duration of symptoms. Now, this child has been having symptoms for 3 weeks. Most bacterial infections, especially if they're treated, they just last for 5 to 7 days or maybe up to 2 weeks. So 3 weeks is quite a long duration. The only situations in which one would think of these infections to prolong would be if either the child has got a very poor nutritional status, he's malnourished, or he's got an underlying immunodeficiency to start off with. It's not unusual for a kid who's got a common variable immunodeficiency or HIV to present just with the GI infection at around 8 years of age. And only in such a setting, I would think of an viral infection like CMV. The second possibility would definitely be IBD in this child. Child's 8 years old, so he fits into the age group. There's no family history, but in Indian as well as Asian settings, the family history is quite rare. It's just 1 to 2%. As compared to the West, where it's reported in up to 30% of families, there's a family history. The duration of symptoms, though, is quite short, just 3 weeks. But I personally think that the episode that he had 2 months ago, I mean, just it lasted for a short duration, may be a part of the same illness. And probably he had ongoing low-grade symptoms, which have again flared right now. So, yeah, so definitely IBD is a possibility in this child. Tuberculosis is something you would always consider in the Indian subcontinent, though the absence of fever and the absence of any extra abdominal symptoms. The child doesn't have any respiratory symptoms, there are no cervical or axillary lymph nodes, would be a bit unusual, but you may not see that in a significant proportion as well. I wouldn't really consider colonic polyps or solitary rectal ulcer syndrome in this particular child. He has clear-cut colitic symptoms, and a child with polyps would present more with painless hematochezia. The only situation where I would actually consider a polyp would be if they're like two separate diagnoses, like he had a gastroenteritis and now he's bleeding because of the polyps, but I think it would be a bit unusual. I would consider a vasculitis in this child, like Behçet's or HSP. Though this child doesn't have any extra intestinal symptoms, he doesn't have arthralgia, arthritis, any rash, or any ocular symptoms, but definitely I would keep that vasculitis at the back of my mind. Allergic colitis is something that I would not consider at all. The most common food allergy that presents with such colitic symptoms would be bovine milk allergy, cow milk protein allergy. And these children, they generally present before 3 years of age, and by 5 years of age, a large majority of them actually outgrow their symptoms. So presenting de novo with such symptoms at 8 years, so I wouldn't really consider allergic colitis in this child. Drug-induced colitis, well, because of non-steroidal anti-inflammatory, it's something that's not very well described in children. It's something more described in adults, but even children who have symptoms because of NSAIDs, they generally have an underlying IBD or something, and the NSAIDs trigger off symptoms. So drug-induced colitis, de novo is also something I would really consider very lower down in this child. So my top possibilities would be an infection, and then IBD, tuberculosis, and a vasculitis.
Thank you, Dr. Rishi. So to summarize, this first two, infections and inflammatory, would be a differential diagnosis. The others, though they are causes for blood and mucus diarrhea because of the reason stated, would not be considered higher up. But initially, when they present with only 2 weeks or 1 week, you must consider that this could be the differential diagnosis and it's not a straightforward IBD. Thank you, Dr. Rishi, for that clarification.
Can I chip in?
So we'll go on with the case.
Maybe, yeah, I just wanted to say that in this patient where the other family members also had similar presentation and this child got prolonged, we should definitely consider a C. diff related colitis also, because that may be one of the reasons for the event being prolonged and then later on developing blood and mucus in the stools.
Then if you see here, there is infections and then there is inflammatory. At your center, would you reverse the order of your differential diagnosis, think of IBD first and then infections, or would you just, because we belong to the infection region of the world?
I have to tell you a secret. There are many infections in Israel as well. But I think that I think the story here does not point to infection as first point, unless, as Anshu said correctly, I mean, C. diff is certainly high on the list. But other than that, it started watery and became bloody only after 2 weeks. And after 3 weeks, I mean, there's a nice study showing that after 3 weeks, whatever infection you have, it goes away with treatment or without. So after 3 weeks, he's only deteriorating. He's not letting getting better. There's new onset of blood. And if we ruled out C. diff, I would be highly surprised if this is related to Shigella or Salmonella, etc. So hemolytic uremic syndrome, HSP, vasculitis maybe, but lower in the risk. I mean, these patients will be highly suspected as having IBD in my region.
True. Thank you, Dan. Even in our region, we would be considering inflammatory bowel disease, but because it's like Dr. Rupa said, an infection-prone area, and 3 weeks, it's either here or there. It could go either ways. The other thing that Dr. Anshu was also mentioning, do we consider amoebic dysentery in these patients, which can prolong for such a long time? Do you still see these kind of patients presenting and coming out with the diagnosis of amoebic dysentery, Dr. Anshu?
Amoebic colitis, Geeta, would be like 1 in a year diagnosis. It's not, in my experience, it's not a common cause, but occasionally, yes, we have had, like I have seen only 2 children up till now who were having amoebic colitis, which was presenting. So I would not consider it as a very common condition, even in our country.
I think, Usha, that is a very important point you have said. We are not seeing that much of amoebiasis or amoebic dysentery getting admitted or serious patients these days, maybe because of over-the-counter metronidazole, which is available. But even in adults, or I think the numbers are lesser.
Having said that, we've had a few children whom we clinically suspected polyp or possible solitary rectal ulcer syndrome and posted them for colonoscopy. So it's not part of our routine agenda to do a stool culture or give them a course of flagell before we take them for colonoscopy. Normal children with normal formed stools, but passing a little bit of blood and a little bit of mucus. And we were surprised to actually find a few ulcers in the rectum. These are just 2 or 3 cases. We realized that they were actually amoebic colitis, and they've been going on for actually 3 months at a stretch without any metronidazole. So I guess if there are people giving lots of metronidazole, then the tertiary care centers don't get to see any amoebic. But if you get the one odd case where you don't treat them with metronidazole, and they actually present differently, so you suspect a polyp, but sometimes you get an amoebic proctitis.
Point is noted very well that though they may present with minor symptoms and we do not suspect them, this could be an incidental finding, and amoebic colitis can surprise you. It's a rare case, but can surprise you, even though clinically we would be looking at inflammatory in this patient. We'll go on to the clinical examination of this child. He is actually well in himself with normal growth parameters, except for mild pallor. There's no dehydration, no skin lesions or clubbing. There's no aphthous ulceration. He has no extra intestinal manifestation, and except for a vague tenderness in the lower abdomen, he has no findings, no perianal indicators of IBD. And these are his investigations which got done because he was ultimately referred for endoscopy and further evaluation. And these are his labs. So I would request Dr. Srinivas to kindly interpret these investigations.
So the hemoglobin is low. Well, he has a colitis, so due to any cause, I think the hemoglobin could be low. I would keenly watch at the platelet count. Normally, if it's an inflammatory colitis, I would expect a lot of thrombocytosis. I don't see thrombocytosis here. I would expect the CRP to be usually much higher, but sometimes the CRP, ESR are non-specific inflammatory markers. ESR normally is expected to be less than 20. So if the ESR is about 20, it again indicates a mild inflammation. It doesn't differentiate infection from inflammation. Albumin levels are usually above 4 in a well-nourished child. Given how the Indian child is, or from what socioeconomic status is, still you would expect an albumin of more than 3.5. So I think this is something chronic going on in this child. So my tendency is to veer towards chronic colitis. So possibly IBD still needs to be ruled out. The pus cells are still 20 to 30, 15 to 20 RBCs. These do not indicate any particular diagnosis, but just simple colitis. A good ultrasound by a trained sonologist who is used to looking at the bowel can actually look at thickening of the bowel, especially in the ileocecal region, which could give us an idea of whether this was a transmural involvement or maybe there is some Crohn's or ileocecal tuberculosis going on. But sometimes the ultrasonogram can miss colitis as well, unless you have a very thin abdomen wall in the child. So all that we get information out of this is I don't think we are able to make a diagnosis of whether this is IBD or not based on this set of investigations. But based on the long-standing history, given that he's had a reasonable amount of antibiotics and he's not responded, he has a mild anemia, hypoalbuminemia, and still unresolved colitis, he does need further investigation to rule out an IBD.
Dr. Srinivas, there is a mention in the stool routine of an EH cyst. This is a often reported lab investigation. So would you give any importance to that? Because
trophocytes are probably more important than an EH cyst. So he's had a course of metronidazole. The point
here is that EH cyst is...
He's had a course of metronidazole, and usually metronidazole very easily treats EHS, and sometimes you may have Entamoeba dispar, which is a common cell, and sometimes these cysts are very often mistaken for the Entamoeba histolytica cyst. So if you're still in doubt, I think you give him another course of metronidazole, but if he's had a proper course of metronidazole, I think we should leave out the possibility of infection, move on to look at other possibilities of colitis, most probably an inflammatory colitis.
This is just to thank you, Srinivas. This is to emphasize that EH cyst should not be taken as sine qua non of amoebic colitis, because it's a common mistake with many clinicians. Dr. Dan, would you like to stop with these investigations, or would you like to add anything onto what has been done for this child?
I think it's good enough. If it's probably iron deficiency, the low albumin, only in acute severe colitis of 1 week we would have expected such a hypoalbuminemia. So I share the feeling that this might be a bit longer issue. We have elevated the serum markers, not too much. So, but as we see with ulcerative colitis, we have to remember that 1/4 of cases of mild ulcerative colitis present with normal labs. So normal CRP, ESR, hemoglobin, platelets, everything is absolutely normal. So normal labs don't mean lack of IBD. But here, continue investigation. I wouldn't do calprotectin to your question on the first slide. I wouldn't do serology. I would just continue as you have here.
Yes. Thank you for that clarification. So we have in summary a child with bloody diarrhea with a history of 3-week diarrhea, not responding to antibiotics, clinically well, and with a lab suggestive of increase in inflammatory markers pointing towards IBD. So Srinivas, what would be your next step for this patient?
Top and tail. He needs upper GI and colon with multiple segment biopsies. So you need to take biopsies whether or not you see a normal looking mucosa. I think this kid requires an endoscopy, and endoscopically normal, you don't come out. You have to do diurnal biopsies, antral biopsies, esophageal biopsies. And if you do a colonoscopy and you think that one segment is possibly going to be the same as the other, so no need to take multiple biopsies, no. You have to take biopsies. You have to do a terminal ileocolonoscopy. So you have to examine the ileum. So a colonoscopy is not over if you reach the cecum, and take biopsies from the ileum, cecum, ascending colon, transverse colon, descending sigmoid, and rectum. And send the separate box.
Thank you, Srinivas. This is, yeah. If this child has been referred to a pediatric gastroenterologist at this stage, probably that would be the next step. One of us is fine. But if it's still with the clinician, then sometimes the clinician tends to wonder whether to refer the patient or not. So for this in the algorithm, there's a question of whether fecal calprotectin can decide, because it's very difficult for a clinician to decide whether this requires endoscopy or not. So is there in the algorithm, since this fecal calprotectin comes higher up, do you do it routinely? And here I would like to ask Professor Lee, in his clinical practice, if a child like this did present to his clinic, your opinion about fecal calprotectin, do you do routinely? Do you depend on it? And if at all you do, when do you do it?
Thanks for asking me this question. No, I wouldn't do it routinely. I think definitely not in this setting, because if this child still have a presence of a bloody diarrhea, you expect that the values of a stool calprotectin will be elevated anyway. So I don't think it will add any values to our investigations of this child as far as possible. I would do it if subsequently this child has been confirmed to have this ulcerative colitis, or maybe slightly rarely Crohn's disease. Then I would use it as a step to monitor the response to treatment. But apart from that, in this setting, I wouldn't do. And then I think we should also realize that the values of stool calprotectin in the first few years of life, especially the first 12 months of life, is much higher as compared to older children or in adults. So we can we need to be beware of this limitation. So no, I wouldn't do in this situation.
So this fecal calprotectin, even in our setup, in our clinic, I'm sure all the other panelists would agree, we don't do this for any patient actually. We do it very rarely for patients who are on treatment and to check for flares. But even then, I think it's easy to get an endoscopy and confirm our findings in an Indian setup. Dr. Dan, when would you do a fecal calprotectin?
We use very often calprotectin to follow our patients. So once they are in remission and they're feeling good, if CRP is high, I will not do calprotectin. It's obvious that there is inflammation. But if CRP is good and the patient is feeling well, we will follow calprotectin every 3 to 6 months and ensure that it's declining. Often I will dictate routine surveillance endoscopy to ensure endoscopic healing by the calprotectin. We will monitor response to treatment by calprotectin. So if someone had 1,000 and we'll start the tasty and healthy, and now it's less than 100, I'm very happy about it. With ulcerative colitis, if PUCAI is 0 and calprotectin is less than 100, there is almost zero chance that the patient has inflammation in his bowel. So this is really we don't need to do often endoscopy. So monitoring our patients, I do it quite often, but for diagnosis, usually it's not helpful.
Dr. Geeta, if I might chip in, I think the value of calprotectin is to rule out a colonoscopy than rule in. If the decision is already to scope, then I think we go ahead and scope. But if you have a huge list of patients where you do not want to be scoping simple irritable bowel syndrome, then maybe as a screening test to say, okay, he is having normal fecal calprotectin, he's more likely to have irritable bowel than IBD. Let me not send this patient to a specialist. That's the value and use of a fecal calprotectin, apart from using in inflammatory bowel diseases, very well pointed out by Dr. Dan.
Thank you for both your points. So this is just to emphasize that fecal calprotectin is not to be used for screening or diagnosing IBD, but once it's the case of diagnosed as IBD, it can be used for assessing flare and to assess the importance or the compliance of treatment and the efficacy of the treatment. At the same time, if you have a doubt whether the patient has got an IBS or an IBD and you are hard pressed for endoscopy, a low fecal calprotectin can decide whether you need to give priority for endoscopy. I think that's what you need fecal calprotectin for. So that's the same in our country. I think we don't use fecal calprotectin on a regular basis for most of these patients. In our setting also for assessing flares, we don't use fecal calprotectin. We go by CRP and we go by the Pukine PCI score. What about the role of serology, Professor Lee? Do you tend to use this in IBD to even differentiate conditions, and what about its role for screening?
No, in my practice, I don't do serology at all for this obvious reason. If I suspect IBD, then I would subject the child to do endoscopy and colonoscopy so that we can confirm with histology. And secondly, in Malaysia's healthcare setting, this serology is not covered by, it's not easily available in a government hospital and not covered by this health insurance. So it be considered as an out-of-pocket expenditure. So and thirdly, the sensitivity and this specificity of differentiating UC from CD by using this in this pair of serology, especially ASHCA, the sensitivity for Crohn's disease is not that great. So in this setting, no, I won't do, and in my personal practice, I don't do it that often as well.
Thank you. That's not used for screening, and it is not used on a clinical basis. Possibly may aid in categorizing a case of IBD undeterminate or unclassified, but not on a regular basis, and it definitely does not add to the treatment. So no, we would not do on a regular basis. Other biomarkers, though there are many studies which point out to the role that it may possibly play, as of now, it's not useful in clinical setting and should not be really encouraged. Now, like we were mentioning, endoscopy in many adult gastroenterology settings for the pediatric patient can be cumbersome because they're not sure on how to prepare these patients for scopy. Sometimes the preparation is inadequate. They're not able to do a complete study. The child requires anesthesia, sometimes special equipment. So adult gastroenterologists who also have to deal with children and who are not equipped to deal with very young children sometimes have encounter problems. Like Dr. Srinivasan was saying, I was also listening to what he was saying, that he would prefer to do upper and lower GI endoscopy for all patients, or irrespective of whether they present with the lower GI bleed alone or not, because all the lab manifestations would suggest that there's a chronic disease, and he would prefer to do upper and lower GI endoscopy both on this patient. Professor Lee, would that be your method of approach to this patient also?
Yes, in this case, since it's the first presentation and we are not entirely sure whether he has a UC or CD, then yes, I would do both upper endoscopy as well as colonoscopy, because you'll be surprised that although clinically he's more likely to have a colitis and therefore probably ulcerative colitis, but he could have Crohn's colitis as a first presentation. So yes, I would do, and I would take a biopsy from esophagus, from the stomach, and from the duodenum, and do this ileo colonoscopy, and do a take biopsy from terminal ileum in the first instance, and then colon and every segments of this large intestine. We have done an audit in our unit, and our intubation rate for cecum is 96% or 97%, and about 95% of cases where the intubations of terminal ileum is indicated, and we were successful. So in Malaysia, we are quite fortunate that we have adequate number of pediatric experienced and well-trained pediatric gastroenterologists who are well credentialed to perform a procedure. So, but I think as faced in many countries in this part of the world, some of the older children, especially teenagers, those who are maybe 15 and above, sometimes they are, in the first instance, they are seen by our adult colleague. In that instance, the size no longer an issue. So our adults colleague usually are quite competent in doing this procedure and making a diagnosis. But then again, we also in my institutions, since we work under the same building, and we work closely with them, so some of these complicated cases, they also refer to us. So to sum up, in this instance, I will do upper and lower endoscopy and take adequate biopsy from each of the segments.
So I'd like to emphasize that point, that upper and lower GI endoscopies have to be done in any case where IBD is suspected, whether it's ulcerative colitis or bleeding PR or Crohn's disease, and mandatory biopsies. So in the adult world or in the adult gastroenterology side, they emphasize mostly on taking antrum biopsies and not on the esophagus or duodenal biopsies. But in pediatrics, we insist on having all biopsies, esophagus, antrum, and duodenum, like Dr. Lee and Dr. Srinivasan said. And when we're doing a colonoscopy, we take a terminal ileum biopsy, segmental biopsies from all sides of the colon, including a separate rectum. Dr. Dan, would you like to say anything on this?
Yes, you said it all. Upper and lower endoscopy in all IBD cases. This is part of the Porto recommendation. That's what we do in practice.
Yes. Sure. So this is just to emphasize that. Now, Dr. Anshu, I would like to ask you, like when you do endoscopy for these pediatric inflammatory bowel diseases, sometimes the findings may not be what we expect, or sometimes they may be a different kind of finding. So what would be these challenges that you would still consider IBD, even though the findings may not be typical?
So basically, from what I understand, you're asking me like what is atypical ulcerative colitis. Like in ulcerative colitis, we normally expect that the rectum would be involved the most, and then there will be a reverse gradient of inflammation. So first and foremost, if I find that the rectum is not macroscopically involved, that may still be compatible with the diagnosis of ulcerative colitis. But before I interpret these facts, I need to take very proper history of any topical therapy being given to the child, because that might be one of the reasons for this kind of a presentation. This may be seen. And again, the biopsy will not show that it is normal. The biopsy would be abnormal. So it's only the macroscopic rectal sparing and not the microscopic rectal sparing, which would be compatible with ulcerative colitis. And the second thing might be that, yes, if there is a left-sided disease and there is a periappendiceal inflammation, so that will not be interpreted as a skip lesion, and that would be compatible with the diagnosis of an atypical ulcerative colitis. And apart from that, obviously, we may not see features of chronicity on the biopsy. We may find sometimes that there may be some small ulcers in the stomach, which would not be incompatible, which would again go in along with the atypical UC diagnosis. Similarly, focal enhancing gastritis, if it is present, does not mandate that it becomes Crohn's disease. So these are the changes which may be present, and then we will group this patient as an atypical ulcerative colitis rather than ulcerative colitis. And in Crohn's disease, obviously, it would depend upon the time, on the lesion where it is. We may just find in children, most often we find the ileocolonic disease. So only the ileum may be involved. And that's the reason that we need to do an upper GI, because in about 6 to 7% of patients, we may find granulomas in the upper GI biopsy, and that might give you a diagnosis of Crohn's disease. And definitely we need to differentiate it from tuberculosis and obviously from CMV, Crohn's disease. We need to differentiate, but more important is the Crohn's disease and tuberculosis, which need to be differentiated, and which is a very difficult scenario. And in fact, here people have also tried doing ASCA, and I would like to say that that also has not been found to differentiate between these two entities. So, but endoscopy is definitely going to give us a clue in this patient who has presented to us with blood and mucus in the stool. So we will get some answers from the endoscopy.
Well said, Arshad. We're just going, endoscopy is the next step, and biopsy would be the next decision maker. So the case endoscopy was done for this patient who he had this kind of finding throughout the colon, almost pancolitis-like picture, with a relatively sparing or lesser involvement of the rectum, but it was not completely normal. However, we were completely sure that this is going to be an ulcerative colitis, but the biopsy came back as cryptitis with the distortion of crypts and crypt architecture, with crypt abscesses and inflammatory cells, lots of them seen. However, no features of chronicity, so to consider acute colitis. Now, the problem also happens that clinically it fits in with IBD, lab-wise it fits in with IBD, and even our endoscopy, we are so sure it's going to be IBD, but the biopsy, they would not give us a proper or a complete diagnosis. It still says acute colitis. So, however, early IBD cannot be ruled out. What would you do in this kind of situation, Dr. Anshu? Would you consider IBD and treat as IBD, or would you give them some more time and do a repeat biopsy later?
No, I would say that there is some distortion of crypt architecture, and it is not absolutely, I would like to see if there is any Paneth cell increase in the number, or if I can see some Paneth cells on the left side of the colon, that might give me one more clue. But he has been appropriately treated with antibiotics. There is a longish history. The child has a low albumin. He has had a past history. So overall, I am tilting more towards the side of IBD. And I would, in fact, I would treat this child as IBD, as an ulcerative colitis at this point of time, with all the information that I have. Because he's received about 10 to 2 weeks of, pardon? He's received about 10 to 14 days of antibiotics, so that's good enough. And we have multiple pointers which are suggesting that it's more likely to be an ulcerative colitis. So I would go ahead and treat him like an ulcerative colitis.
All right, Professor Lee, what would you do?
Yes, I agree. I would treat as go ahead and treat as ulcerative colitis.
Dr. Dan, would you agree on this, or would you still?
Yes, certainly. One third of children, as opposed to adults, there's a higher rate of non-chronicity as initial biopsy. So 1/3 of patients, or even 40% of patients, will not have chronicity If infection had been ruled out, this is for me, it's IBD. I don't need chronicity to treat IBD.
It's important that this patient gets to the right hands also, because if acute colitis is the biopsy report, sometimes if it goes back to the clinician, they tend to treat it with antibiotics. And I think pediatric gastroenterologists are necessary in this situation for us to start treatment with a positive hand. So this has already been answered. So sometimes even in Crohn's disease, you get no microgranuloma, but clinically it appears to be Crohn's, and therefore it is up to the pediatric gastroenterologist to take an active step and start treating against this. So I would just rush in through. This has already been answered by Anshu. A panel cell metaplasia would be actually suggestive of a IBD. What about imaging at this stage? Now you have this patient who is acute colitis, most likely an ulcerative colitis. Would you necessarily want imaging, Dr. Srinivasan? Or
current practice is to evaluate the small bowel, and we prefer an MRI over the CT because it's got less radiation. All patients at first evaluation undergo some form of a small bowel evaluation, and if they can't afford an MRI or if it's not possible, at least a barium meal follow through to make sure that there are no strictures or involvement in the small bowel. Irrespective of whether it's CD, UC or IBD.
Even if there is patients.
I would not agree with this, Geeta, because barium has got no role. Means in today's age, barium will follow through.
No.
Hello?
I completely agree. I think MRE is the way to go.
No, I was just saying that in today's age, a barium meal follow through would have no role in evaluating the small intestine, especially in this scenario where you are not having anything to suggest like an obstructive pathology. You either go ahead with a CT or an MR, or you may defer it in this patient who has everything like ulcerative colitis, so it may not be mandatory at this stage. Obviously, in rest all other patients where you have any doubt, you would like to do a small bowel evaluation, but I would not do barium in these children. I would definitely do either of the other two tests, either CT or MR.
Geeta, we need to wind up this discussion.
This is the last slide.
Because we run out of time.
The barium is not to be done. Yeah. We do not do barium. If at all you're doing an investigation to assess the small bowel, it will be a CT or MR enterography. And that's more important in Crohn's disease. It would not play much of a role in ulcerative colitis at the outset, but if there is a doubt or an atypical ulcerative colitis, that's where this would come in place as according to this algorithm also. You have an atypical UC, you're not sure whether it's Crohn's or an indeterminate unclassified masquerading as an UC, in which case you will want to do an MR enterography to find whether it is Crohn's disease or ulcerative colitis. Otherwise, we have just gone through this algorithm with this patient. So in summary, I would like to say that any bloody diarrhea or chronic diarrhea extending beyond 3 weeks, you would like to consider inflammatory bowel disease. All these are pointers: external manifestations, anemia, fatigue, body weight loss, abdominal pain with labs of thrombocytosis and hypoalbuminemia and raised inflammatory markers. Fecal calprotectin and serological markers are not useful. Endoscopy and biopsy is mandatory and could be even diagnostic. Even if it's not diagnostic, it helps us, the macroscopic view helps us to make a diagnosis and move forward in this patient. Imaging required if there are GI small bowel symptoms, or for cases of Crohn's disease, yes, and also for atypical cases. Do not miss any mimickers. These are pictures of allergic colitis, which mimicked an ulcerative colitis completely, and biopsy helped us to make the diagnosis. These are ulcers in a patient with Henoch Collins purpura. These are all our cases which have come over the years. This is a case of SRUs which presented with blood and mucus diarrhea, and even polyps can present like this. This is a 10-year-old boy who presented with blood and mucus diarrhea, had a sibling with Crohn's disease. Somehow the ulcers looked very different, and the biopsies came out as CMV colitis. Subsequently, we re-evaluated the sibling and found that both of them had immunodeficiency and not inflammatory bowel disease. And sometimes we have surprise mimickers. A child who's been diagnosed as UC and came for an opinion because not responding with mesalamine looked completely like, the initial parts looked completely like inflammation of the bowel. But ultimately, the last picture shows some venous malformation turned out to be a Klippel-Trenaunay syndrome, who has been treating as ulcerative colitis for more than 2 years. So this is just to remember that there are some mimickers which can present in the form of IBD, but definitely IBD is something which you would not want to miss in all these patients who present with a bloody diarrhea of 3 weeks duration. So I would like to thank all my panelists for their valuable comments and Dr. Dan Turner for being here and helping us in making decisions for this child. Thank you, Dr. G. N. Ramesh, and over to you.
Thank you very much, Dr. Geeta, and each of the panelists and everyone who contributed to this panel discussion. Well, I can see Rupa smiling because it's time for the cultural break, and she had promised that she will speak in Bangla, and it's over to you, Rupa, for your Bangla and our observations from our Bangladesh friends.
I think we've had an excellent discussion so far on pediatric IBD, and as with the spirit of IBD Emerging Nations Consortium, the theme for today's program is the country that we are projecting a strong partner and pillar of IBD-ENC is Bangladesh. Namaskar সবাইকে আর এখানে আসার জন্য I am much a Bengali and I am very much close to Bangladesh. And, you know, West Bengal and Bangladesh were one country once upon a time. But thank you so much. And before wasting any more time, it'll be over to Professor Farooq and Professor Masudur Rahman to tell us a little bit about how IBD is increasing in Bangladesh, and a warmth of people, wonderful food, and I have been there, and I'm always, excited about going there, not only for the academics, but also the extremely beautiful warmth and hospitality. Over to you, Professor Farooq. And namaskar to all my Bangladesh friends. Yeah. I know all the doctors there, and it is a very big, warm welcome.
Thank you, Rupa, for your kind appreciation. And I must give you due thanks for selecting Bangladesh for this, to speak on this August gathering. Can you hear me, Rupa?
Yes, we can, and we can see the slides as well.
Once again, I am giving you thanks for selecting Bangladesh to speak in this very prestigious meeting on IBD. And, you know, Bangladesh is a very small country of this region. And you see our area is only 150,000 kilometers, but very densely populated, having a population burden of about 170 million. And in Bangladesh, you know, we talk about IBD, we always talk about Professor A.K. Azad Khan. I think all of you know his name, because A.K. Azad Khan, he worked on IBD back in mid-70s, and he discovered the active moiety of sulfasalazine while he was working in Oxford. So he is a great scientist of this soil, and I will take few minutes time from you to hear something from him.
Depending on all my viewers, executives and organizers and participants of this IBD Masterclass presentation. I'm truly delighted to see all the gastroenterologists of this region along with stalwarts from other countries working together fight inflammatory bowel disease under the platform IBD-ENC. I'm grateful and feel privileged for being invited to say something about the story of finding out the active agent of salicylic azole known as serology in UK, salazine in USA. This molecule was introduced by a great Swedish physician, Nana's Fars, from a wrong notion. Because this was the time when sulfonamide was being introduced as a chemotherapeutic agent, and aspirin or salicylate was being used as an inflammatory agent. She thought that if these two can be combined into one molecule, it will produce a wonderful drug for rheumatoid arthritis. Because she used to believe rheumatoid arthritis is an infective disorder. And this was achieved by the chemist of Panelists, a company that existed in those days. So the substance was introduced, and many clinical trials showed its efficacy in ulcerative colitis. When I started working with this molecule, that was middle of 1973. And I'll make a long story short. People used to believe that the active part of this molecule is salicylate, and sulfapyridine is simply the carrier. See, if the substance is given singly, let's say, sulfapyridine or salicylate by mouth, they will be absorbed in the upper gut. They will not reach colon. So, that's what happens. So when I looked through it critically, I thought, whatever they have concluded, this is one possibility. The other possibility must be that when a person has an attack, then they have diarrhea. But because of financial reason, that was not possible. But that would involve glass, this will create new compounds. So they will have to be tried in animals and involve large amount of expenditure. So I thought a very simple idea, that we should make enema preparation, double blind, and try sulfapyridine, 5-ASA, and salicylate. That's what we did in double blind fashion, and then found that the activity is in the 5-ASA, not in the sulfapyridine. We also by that time knew all the dose-related side effects are with sulfapyridine. So that gave us a wonderful opportunity to make a new drug with 5-ASA. Also on continuing for binding 5-ASA with another 5-ASA back to back. And that is diamond. So we did not patent it. We intentionally did not patent it because that will make the drug more expensive and it will take longer time to market it. So we deliberately did not patent it, and the drug was made, marketed the same year that we made the publication, and is still being used today. I'd like to thank all my viewers. A brilliant success for the IBD-ENC consortium in their endeavor for treatment of inflammatory bowel.
So, respected participant, you heard the story of a scientist who discovered this molecule, the active moiety of sulfasalazine, that is 5-ASA compound. So, he is a great son of this soil and a great mentor also. And you know that Bangladesh has got a very important history and heritage, and I want to tell you a few historical events of Bangladesh. I want to tell you about 1952 February, that was 21st February, thousands of students, teachers and common people assembled in Dhaka to press home their demand to establish their demand that Bangla must be the state language. And ultimately, after this revolution, Bangladesh could recover and establish Bangla as the state language. And in recognition of this, UNESCO declared 21st February as International Mother Language Day back in 1999, which is now observed worldwide. And in 72, we fought for our independence. And independence and the independence movement sparked after the great speech of our father of nation, Bangabandhu Sheikh Mujibur Rahman, on 7th March 1971. And you see that speech has been one of the greatest of this time. And this speech also have been recognized by UNESCO as one of the very greatest historical speech of the world. And we are also proud to say that Bangladesh is a secular country, 100% secular country, and the people of all religions could observe their all religious rituals peacefully. You can see in this video that this Muslim, Hindu, Buddhist, Christian, and all other religious group could observe their rituals very peacefully. And we do have some universal festivals which has been observed by all spheres of people. You can see of this one is a celebration of Bangla Noboborsho, that is Pahela Boishakh. So all people of all sphere used to participate to celebrate these events very peacefully. And we also observe 21st February as our Mother Language Day and Day for Language Movement. And people from all sphere of the society come to this monument in barefoot to place floral to this monument of great language movement. And also to observe 16 December and 26 March as a memory of our independence war. People used to go to this national monument some 30 kilometers away from Dhaka city to place floral over there. And we also have very unique natural beauty and some historical spot to attract the tourists from different areas of the world. And of this, important one is this hill treks. We do have hilly areas where a lot of people used to go there to see natural beauties over there. You can see a small water channel in between two hills here. And this is the scenic beauty of a tea garden in Sylhet. Tea from Bangladesh is very famous worldwide. And this is the very scenic beauty of our Cox's Bazar beach, the largest sandy beach in the world, with a marine drive by the side of this beach. And we do have other beautiful places, natural beautiful places. This is one island which I think all of you know. This is San Martin. San Martin is a very famous island for the tourists, and most of the tourists used to go there to enjoy this island. And we do also have a lot of other things, including this mangrove forest, Sundarban, which is also the largest mangrove forest in the world. And a lot of people used to go there to see its beauty. And you can see a very indigenous boat over there to enjoy this forest. And you can see this royal animal. This is Royal Bengal tiger. All of you know that this is very elegant animal, exclusively seen in this Sundarban area. So this is a very important attraction for tourists from different countries. And Bangladesh in recent time, you see, achieved a lot of developments in different sectors, including this communication sector. You can see different types of flyovers and big bridges over there. And this is Padma Bridge, which is now under construction. And this is a very big bridge with big budget program. And Bangladesh is doing these bridges by their own financing without any help from anybody else. And this is Jamuna Bridge. This is also a very big bridge made in Bangladesh, and this has got important role in improvement of our communication sector. And Bangladesh also entered into use of this nuclear energy for production of this power plant, and it is under construction. Hopefully within a couple of years it will be in function to supply power for this country. And I will tell something about our health service system. And over the last couple of years, Bangladesh has got impressive improvement in healthcare services, and people now could have their healthcare services at their doorsteps with the establishment of these community clinics in the village level. And we also have Upazila health complexes. We also have district hospitals, big comprehensive hospital in every district. We do also have medical colleges, big medical colleges, hospital like Dhaka Medical College. I think most of you know this name, Dhaka Medical College, and there are other different medical colleges, big medical colleges. And recently, the government has also established a specialized hospital in Bangladesh. And of this specialized hospital, recently it is a great news for us that in Bangladesh recently we have our National Institute, Digestive Disease Institute, which is the name of which is Sheikh Russell Gastro-Liver Institute, established in Dhaka recently. And it has been inaugurated in 2018 by our Prime Minister Sheikh Hasina. So we are now working here, and this is a big institute, 250-bedded institute, and we have got all modern GI facilities in this institute. And by this time we have started our function, and we have also started our academic activities over here. So this is a hospital for which we can feel proud. And credit goes to our Prime Minister. She is very much interested to expand our modern healthcare services to all the levels of the country and to the doorstep of all people of our country. And now I want to tell you about the history of gastroenterology in Bangladesh. So Bangladesh, the services of gastroenterology started back in 1977 with the hand of Professor A.K. Azad Khan. He joined here in 1977 after completion of his study in UK. And following him, Professor Mahmood Hassan, he joined in gastroenterology department of then IPGM, and now it has been converted to Bangabandhu Sheikh Mujib Medical University. He joined here in 1982. With these two great teachers, great clinician, the journey of gastroenterology started in Bangladesh. And so the journey of gastroenterology started back in 1977. And by this time, we could be able to have more than 250 gastroenterologists who are working in different levels of this country. And the gastroenterology services is now available almost all over the country, and almost all big medical colleges, we do have gastroenterology services, all services available in medical colleges. And we also have got some specialized clinic in different big hospitals, which includes this fatty liver, IBD clinic, and other clinics also. In Sheikh Russell National Gastro-Liver Institute, we do have IBD clinics regularly on Monday, and IBD clinic we do also have in some other big medical colleges. And all of you know that IBD is increasing in this region of this country, and which is also true for Bangladesh. In Bangladesh, IBD is also increasing, and roughly it is around 3 per 100,000 people is now having IBD. Although, unfortunately, there is no national registry, but we do have one recording system, and we are now moving towards establishing national registry for IBD. And in Bangladesh, you see, ulcerative colitis is more common than Crohn's disease. And one thing is still not comfortable for us is that we couldn't go for early diagnosis because of lack of awareness regarding this illness. But in recent time, the awareness about this IBD is increasing, and nowadays the delay of diagnosis is now going down. So nowadays diagnostic delay is now reducing, and we are now able to do diagnosis earlier than in the past. And high rate of still we are using antitubercular drug, particularly in CD patients, sometimes as a therapeutic trial or sometimes to exclude tuberculosis. So use of anti-TB drugs is still high in our country. And nowadays we are also getting high frequency of complicated IBD in our country, particularly complicated Crohn's disease patient in our country. So this is one thing, and we are also having high rate of surgery in IBD patients, particularly high rate of surgery in complicated Crohn's disease patients even in our country. And most of the cases we are giving treatment with steroid and immunosuppressants. So use of steroid and immunosuppressants are very common in our country, and use of biologics has started here. And the use of biologics, although is minimum, but it is now increasing with the availability of this biologics in our country. And the compound, the drugs which are now used in IBD, such as ASA compounds and steroids, all are available in the country. Although we do not have budesonide MMX preparation in our country, we also have immunosuppressants. And recent time, our pharmaceuticals has introduced biologics and biosimilars for use in our country, and we are now using these drugs for our patient. So a lot of advancement has achieved in.
Farooq, can we wind up now?
Yeah. I'm at the end of my speech, so thank you very much for your patience hearing. This is a slide showing in Domitable Bangladesh. You can see here the impressive improvement of different parameters in health sector in Bangladesh, and for which our Prime Minister has achieved a lot of international awards. So these are the indications that we have achieved a good improvement in health sector. And thank you very much for your patient hearing.
Rupa? Thank you very much, Professor Farooq Ahmed, for that window into Bangladesh as a country and gastroenterology and IBD in Bangladesh. And it was particularly nice to watch Professor Azad Khan talk to us, and he is indeed a legend. Okay, we now quickly go on to just the many questions that have come in. I don't know really how to finish up the question. Dr. Jayanti, it is over to you to start off the question answer session. Yes, Dr. Jayanti.
One question is from Dr. Biswas, who says what modalities we should use in diagnosing IBD in children where colonoscopy is also not available. The colonoscopy facilities is not available. Anyone can take up from the panel? Panelists, I'm sure anyone would like to answer that.
I think if colonoscopy is not available, what would you do? I mean, most of our centers would need a colonoscopy. I think Dr. Malati,
I think we should insist that without colonoscopy, you cannot start a definitive treatment for IBD. I think we should make it very clear, because we need tissue diagnosis. And as we've been saying, there's so much of differential diagnosis. And once you label a child as inflammatory bowel disease, you're giving a lifelong diagnosis. So without a complete, you can delay it. There's no harm. They can wait. Nothing is going to happen. But definitely we just have to wait. And then at that point of time, probably you can just, if it's a young child, less than 2 years, you can give some form of, an enteral nutrition, try to decrease the pro-inflammatory diet, give a diet so that you don't do any harm, but somehow we should make it a point. Now, it's not that bad. We do have centers where they do colonoscopy.
There's one other question by Dr. Uddin Ahmed, who says that very early onset IBD with non-classical presentation, can we start treatment without genetic testing?
So I think this is now very clear not to start, because genetic testing has to be done. Now, once you think, and that genetic testing, you don't have to do it for all very early onset IBD. I've given some clear criteria, especially if the infant is less than 2 years. And these are the highest risk predictors: age and family history. Suppose the elder sibling died, that parent will willing to spend that amount of money for genetic. That's why this child came. They don't want to lose the child. They say, don't worry. So that the main thing is finance, and you can send that sample elsewhere and get it done, because the treatment can completely change. No use giving steroids, biologicals. The father came forward and the child, you should see the child now. They are so happy. So I think when there is a different treatment, genetic studies, and if that genetic studies is giving you an answer, I think we should encourage them to do genetic studies. Even antenatal genetic studies are now being done, especially for IL-10R. As Dr. Dan was saying, in China, if 50% of their VE or IBD or infantile onset IBD is IL-10R, they are now trying to push that. I think Srinivas also will agree. I think genetic studies have really changed our thought also.
Absolutely. That there is a learning curve and we keep doing genetics, and it's important to differentiate between pathogenic mutations and variants of unknown significance, because sometimes when we start doing genetics, we actually get to understand that there can be a variety of mutations which may not correlate with our clinical presentation. So clinical geneticists is also sometimes important. We go ahead the next step and also prove sometimes the genetic status of the parents. And then there may be sometimes a reclassification of a VUS, which is a variant of unknown significance, to pathogenic. But if you're dealing with monogenic IBD, I think it's very important that we do genetics very early. And like Dr. Malti said, the importance of basically looking at this very early onset history of consanguinity, and if there is a sibling death, we should immediately start thinking about monogenic Ibd.
Can you tell any of you tell your experience with biologicals in your patients? You know, like there's a question on role of ustekinumab versus adalimumab in pediatric IBD. So how often have you all used? Each of you can just give your experience.
I think all of us have used. I think Rishi has analyzed in this last publication. We have shown that the use of biologicals was more in that younger age group. We were using infliximab, very happy with that, but we were able to choose the child. As we were giving for anyone who presented with perineal fistula, we know it will not close otherwise, and we were using it for moderate, severe. UC, we did not use. Now with ADA, we find it more child-friendly, but somehow less than 6 years of age, infliximab seems to be still good. And otherwise, adalimumab is now taking over, and you know the response is phenomenal. So I think it is now up-end treatment. It's not frontline treatment. It's just that you just start it for a certain group. We are not now talking about step up and all that. All that is gone. Accelerated conventional is also gone. These children require it as fast as possible. Try to give it as the first therapy, and then try to bring them to the. I think all of you will agree to that. No use giving a moderate, severe, a child with hypoalbuminemia with all the predictors, starting with steroids, taking time, and if just talk to them, find out the response to biological seems to be better.
I have a basic doubt. In this very early onset IBD, most of the colonoscopic findings are more in favor of Crohn's, or are
all that is gone. Accelerated conventional is also gone.
No, the findings are more towards like Crohn's, deep ulcers, or you get more like UC, the VEO.
Anyone else can take it up, but you know, depending on thing, we do get both.
Yeah.
But I think what we are seeing, some of them are very mild. I think Srini can tell about his LRBA and all that. Just a mild colitis we had, some of them. Some, this IL-10R, the ulcers are quite deep. Even at the age of 3 months to see such big ulcers, I was quite surprised. Such big ulcers for a child. That is classic. It looks like Crohn's.
No, but the biopsy also comes as granulomas.
No.
That's what I'm asking. So
see, only in CGD you'll get Crohn's. Here you might get, you know, apoptosis as a present. There are some features. You might just get a cryptitis. You might get cryptasis. You might just get a lymphocytic proliferation also. So there are some histological features which tell you if you don't get the classical granuloma, you don't get that.
That's important message, that we don't get features of Crohn's disease. But maybe UC you get.
Ma'am, I have a question.
Yeah.
Yeah, with the newer JAK1 inhibitors are being available now in India, and few trials are also going on in pediatric patients. What do you think? What will be the role in future for pediatric IBD
for this JAK1 inhibitor, pan-JAK inhibitors like tofacitinib?
See, JAK1, actually, we've been looking into it, but
like tofacitinib is
more
available
in
now.
UC
rather
than in Crohn's. In UC also, somehow, I don't know about the others, our response, that group, if they come with acute ulcerative colitis, I think we had good response with surgery. What do you think, Srini? And we just had to have a bridge and then we went to that. The others, majority managed with steroid induction, and we are able to manage with Aza and Mesocol. We're not having too much of problem. I think as they switch over, we may have. And I think Anshu cannot tell because they see more UC than us. Anshu?
That here, the concept is this, that at least we are having an oral biologic. It's still not approved for children. The thing, but
you know this
have an oral biologic, and in adults at least it's working very well for acute severe colitis.
So much of issues with that. When you start reading, you know, the response, varicella coming there, pulmonary edema, all that. Even now, I think it's just taking.
It's still taking up. But what happens is, even if you can save some colons at a younger age, that is.
But you know, we always used to rate you live longer without the colon than with the colon in UC.
You wanted to make a point?
Sorry, no. I was just just hoping that we get some adult experience from you, Dr. Rupa, before we probably think and extrapolate it to pediatric. 1. And 2, it would be very interesting to see how this works for the resistant left-sided colitis in UC.
Yeah, I think the reports that are coming in right now for adult, for tofacitinib, particularly for acute severe colitis, has been very encouraging. Because always things are early. You know, we need to check the lipid profile and things like that have been reported. But overall, there is a trend towards, and new papers are just coming. In the last month or so, we have had papers which are suggesting that tofacitinib in acute severe colitis, even in infliximab naive patients, are giving good results. Now, my only interest is when we see a lot of pediatric patients also, you know, injections and kids don't like it. And when you see an oral biologic, and hopefully, even if it works, I think that will be, we have to watch that page for more details on pediatrics. But I think Partha's question was quite a thought-provoking one, that maybe we can work on this.
I think
the tofacitinib is much useful in UC. And probably would benefit.
Results are going to come out for Crohn's also. The reports look to be okay, but they're still in the trial stage.
At the moment, it is only approved for conditions where biologicals have failed. Yes. But there is now an emerging school of thought which says that it can be used upfront in patients with severe ulcerative colitis. In Crohn's disease, evidence is just catching up. It will be some time before we can use tofacitinib in Crohn's disease. I think with this, I would like to say that we've had a fairly long session. Pediatric IBD is something which evokes a lot of discussion, debates. I think it's good. It's always good that we should have a debate. We should have discussion. We should have exchange of ideas and new ideas too. And today was no different. We've had a fairly invigorating session. And we need to call this to an end because we have just run out of time. I don't think I can allow it to go any further. So for the closing remarks, it's over to my co-moderator, Dr. Jain.
You can tell us about the next meeting and also propose a vote of thanks in one go.
Vishwesh, can we have the slide, please? So, Dr. Jayanti, thank you. Thank you, Dr. Ramesh. Thank you for everyone for participating. And as Dr. Jayanti mentioned, our next meeting is on the 13th of August, 2021, the second Friday of every month. And it's the last but never, ever the least. I must thank our academic partners,
Microlabs Limited, Janssen, J&J, Dr. Reddy Labs, and Takeda for their continuous support for the IBD Emerging Nations Consortium. So, Dr. Jayanti?
Yeah. So on behalf of our course director, Dr. Rupa Banerjee, and my co-moderator, Dr. J. Ramesh, we profusely thank Dr. Dan Turner for his keynote address on IBD in children, and with a wonderful presentation, how he differentiated IBD in children from others, as well as the problems that one encounters in managing children as compared to the adults. And also to Dr. Malti, Satya, Shekharan for highlighting the various aspects of very early onset IBD. And to Dr. Geeta, who moderated a panel discussion beautifully along with elite panelists, Dr. Srinivas, Dr. Rishi, Dr. Anshu, and Professor Lee. And not to forget Professor Ahmed for a wonderful presentation on IBD and Bangladesh. Thank you all and have a wonderful evening.
Thank you.
Thank you.
Good night. Good night to you all.
Good night, everybody. Good night. Good night.
Good night, everybody.
Srinivas. Thank you, Dr.